Hello, everyone, and welcome to the Nutrition and Aging Resource Center's webinar, Navigating Partnerships with Healthcare Organizations. I'm very excited to welcome Dr. Amanda Brewster. Dr. Brewster is an assistant professor of health policy and management at the School of Public Health, University of California, Berkeley. Her research examines how management and interorganizational relationships influence the performance of healthcare organizations. Her recent work focuses on identifying effective strategies for healthcare and social services to work together to address both medical and social determinants of health, including studies of cross-sector collaboration at the community level, partnerships between area agencies on aging and healthcare organizations, and screening for social determinants of health and physician practices. Her work employs a range of methods, including qualitative and mixed methods, organizational network analysis, and longitudinal analysis, leveraging large survey-based and claims-based data sets. In addition to her research on relationships between healthcare and social services organizations, Dr. Brewster also studies quality improvement and organizational learning in healthcare organizations. This work has included research on hospital efforts to reduce readmissions and mortality from acute myocardial infarction. During today's session, Dr. Brewster will identify the importance and positive impacts of fostering collaboration and partnerships between healthcare organizations, senior nutrition programs, and the Aging Network. She'll also discuss strategies and tactics that organizations in her Aging Network have used to successfully establish these partnerships. Before we get started, I do want to mention some housekeeping items. First, we will hold questions until the end of the presentation. Our team will be monitoring the chat and the Q&A section throughout the session. Please write any questions you may have in these two areas. We will start with the Q&A session with the chat questions first. You can also raise your hand using the icon and ask your question orally. At the end of the Q&A session, we encourage everyone to complete the evaluation that is accessible with a QR code or the link that will be placed in the chat. The information you provide will help us during our next webinar. The Nutrition and Aging Resource Center is continuously working to improve the accessibility of events and content. Automated closed captioning will be provided for this webinar. You can enable these captions by selecting the CC in the toolbar or the closed caption in the meeting options. This meeting will also be recorded and made available on YouTube. The video with captions revised for precision will be shared via the Resource Center's newsletter. If you have any questions about captions or additional accommodation requests, please email nrcna@iowa.gov. Finally, we did not seek prior approval for this event for CPEU credits for dietitians. You can still receive credit under the CPE activity type 171-teleseminars webinars. Please visit the CDR website for further instruction. Now I'm going to hand it over to Dr. Brewster.
Thank you so much, Dr. Francis, for that warm welcome. And thanks to all of you for having me here today. I'm really looking forward to sharing some information with you all. So I'm going to start sharing some slides to begin. And today, as mentioned, I'm going to talk about some work that my colleagues and I have done to understand how community-based organizations navigate partnerships with healthcare organizations. And I can see already from monitoring the chat in that first couple of minutes that we've got a really nice spread as far as participants from different parts of the country and different types of organizations. So I'm also really looking forward to your questions and comments throughout. So as mentioned, I'll see if I can keep track of the chat as we go and make sure to address questions at the end if I'm not able to follow everything as we go. So my plan today is I'd first like to do some level setting, talk about some emerging initiatives to link social care and healthcare that have been increasing interest among healthcare organizations across the country in forging relationships with social care organizations. Across multiple different sectors, but specializing in the aging sector. And I will touch on some emerging evidence on some of the some major programs at the national level and state level, and what we're learning about how those work. And then I'd like to move in and spend most of the time talking about research and emerging understandings of how partnerships and collaboration among healthcare and community-based aging and nutrition organizations work, and some of what we're learning about what contributes to successful building of those relationships. So let me start with a graphic that I feel like many of you have probably seen some version of. So I think there's really an increasing understanding in both the health sectors and also social care sectors that when we think about population health and we think about patient health, even at the individual level, there's a growing appreciation of what we've probably known, for hundreds of years, that it's more than just clinical care and stuff that happens in a hospital setting or a doctor's office that influences health, and that in fact, social factors and behavioral factors and environmental factors play a tremendous role in shaping health outcomes at the individual level and at the community level. And so, as healthcare organizations increasingly think about being responsible for outcomes through changes in our payment models, thinking more creatively about how to leverage care that extends beyond the clinical has become of increasing interest in our healthcare sector. And at the same time, we've been seeing emergence of more evidence that there are specific types of social services that address determinants of health outside kind of those walls of the healthcare delivery sector, including in nutrition and housing and income support, that are actually associated with health improvement. So this awareness that health is multifaceted and what we can do to improve health is multifaceted. And that's come, as I mentioned, in a context where healthcare organizations, both health insurers, so payers, as well as healthcare delivery systems like hospital systems, healthcare systems, physician organizations, have increasingly moved towards value-based payment arrangements. So that's shifting payments so that instead of getting paid fee for service based on kind of the volume of care provided to patients, payment arrangements are increasingly moving towards models where organizations are paid based on results. So there's a way to go. So those of you who are more familiar with this area are going to be aware that we're mostly still in a fee-for-service environment, but definitely signals that in the future, healthcare organizations are expecting a move towards more and more value-based payment arrangements. There's also rising awareness of inequities in healthcare access and outcomes across many social dimensions related to social circumstances, including race, ethnicity, and income levels. So healthcare organizations that want to improve equity also are more and more attuned to the important role that caring for patients' social needs can play. And we've seen over the past 5-10 years really policy statements from all of our leading healthcare delivery organizations, payment organizations, policy setting organizations, really signaling an appreciation of the role that social determinants play in shaping health, and a plan to increasingly try to address social needs in the context of healthcare or this has been kind of marked by, I'll just highlight one particularly important, in my mind, policy document that has come out in this stream of sort of understanding the important role that social context plays from the perspective of healthcare delivery. And that's this 2019 consensus study published by the National Academy of Medicine. So if you want to look up one thing, I'd say check that out. This is a really thoughtful and well-researched report that helpfully, I think, came out with 5 activities that the healthcare sector can consider supporting social care integration with healthcare. And so recognizing that there's multiple facets to the way that healthcare organizations might consider acting on this knowledge that social context is important for health. And briefly, those include increasing awareness of individual patient social risks. So, this is encouraging the increases in social risk screening and referral. So, awareness being social risk screening. So, increasingly, we're seeing healthcare organizations adopt systematic approaches to asking patients about social needs. So, food security needs, transportation needs, and then increasingly following that up with offers of assistance. So that's the awareness and assistance. Also, this framework points to the fact that sometimes becoming aware of a patient's social risk is going to allow healthcare providers to adjust the care that they can provide to accommodate a patient's circumstances. So those first three domains, awareness, adjustment, and assistance, all focused on individual patients. And then this also leaves room for the fact that healthcare organizations may also take part in partnerships with other organizations in their communities that are about aligning and advocating for social care resources at the community level, which I think is also really important and relevant here. So appreciating that healthcare organizations can take steps to understand and invest in existing social care assets in their communities. So different sorts of across different sectors, and also potentially partnering with social care organizations to promote policies or promote resource allocation to address health and social needs. So that is my real quick overview of how this interest in aligning social care with healthcare has formed in the healthcare sector. And now I want to give you just two examples of recent initiatives to give you some context of how this is impacting the healthcare sector. And I saw through the chat so far that we've got folks from a variety of different places in the country, including across the US and some here close to my home in California. And I actually am going to tell you about one national scale example and one that's based here in California. So many of you may be already familiar with this first example that I'm going to talk about, which is the Centers for Medicaid and Medicare Services Accountable Health Communities model. CMS Accountable Health Communities model, which was a really important and interesting innovation program that ran for about 5 years, concluding just a couple of years ago, really testing this approach of screening Medicare and Medicaid beneficiaries for social risks and then offering navigation to community-based care for identified social needs. So an example of expanding the focus of these healthcare organizations and care patterns beyond the medical sector and engaging community-based social care resources. So there's a 12-question screening tool that 30 sites or 30 participating sites across the country, and you can see the graphic that I've got here highlights those 30 sites in blue. And then recently, we've got a chance to see the evaluation results since this program has recently concluded. And the hope here was that screening patients for social risks and referring to local care resources for those risks. So like if a patient had screened positive for food insecurity, a navigator would work with that patient to connect them up with a local nutrition resource. If a patient had screened positive for transportation insecurity, that patient would be linked up with transportation resources. And the hope was that this would allow patients to address some of the social determinants that may have increased their health risks and then reduce downstream expensive healthcare utilization. So what we've seen in the evaluation, which was published last year, is that indeed patients who received navigation through this intervention did have a reduction in emergency department visits, so suggesting that there were some important impacts achieved through the screening and navigation approach. But interestingly, actually, when they drilled down into what patients were experiencing, when they received navigation, it was actually quite challenging for those folks to connect up with the social care resources in their communities, and most patients didn't. So it looks like this effect was achieved actually probably through different ways of navigating their healthcare. And potentially not by addressing the social needs. So recognizing this is a complicated pathway. So then the other example where we've seen recent evidence emerge is closer to home and a project that I've worked closely on evaluating for the past 5 or 6 years with colleagues here at Berkeley Public Health in the San Francisco Bay Area where I'm based. So this is part of a state-focused initiative, the Whole Person Care Medicaid Waiver Initiative, which took place in California through 2021. And the program that we've been evaluating is one county's program. So the Contra Costa County program, which was called Community Connect and offered assistance with social needs and healthcare navigation. So not too unlike the nationwide program I mentioned before, except offered a longer period of ongoing relationship with the case manager for around 12 months. And so we conducted a related evaluation. We're able to operationalize a randomized trial and found also that this intervention to understand patients' social needs and help patients navigate social care resources, access things like CalFresh here in California, access community-based food banks, access transportation resources, access housing resources, actually did translate into reduced inpatient hospitalizations. So also increased utilization of primary and preventive care. So illustrating a pathway where it seemed like assistance with social needs, assistance with navigating healthcare were coming together to help patients be able to access earlier care for conditions that might have otherwise, if left untreated, result in more serious manifestations down the road. So these are just two of actually a wealth of other examples that we've seen trialed in the US over the past 5 to 10 years, showing that these efforts to integrate social care with healthcare do seem to show signals that there's a lot of promise in improving health and reducing costs. So both kind of ways of thinking about how this is looking to healthcare entities in your states and your communities. So looking like there is promise, but also that this is very complex. So patients' experiences are quite complex, and these interventions are quite complex. So there's growing appreciation that this isn't a simple fix, but it is a promising fix. So over the past decade or so, I think what we're seeing is pilot efforts and experimentation. I've only told you about two, but many of you will be aware of related efforts in your own communities, in your own states and regions that are along these similar lines. So we're seeing a phase, I think, where this wealth of pilots and experimentation are starting to actually switch into more requirements routines. And so we know at the national level, healthcare organization or health plans as of 2023 now have a quality measure that's focused on social needs screening and interventions. That's HEDIS, one of the kind of quality measure set organizations nationwide has put that out for health plans. And we're seeing some states adopt related quality measures as well. So here in California, where I'm based, California Medicaid plans have an additional requirement to ensure closed-loop referrals to community-based social care resources. So this is something to kind of keep on your radars as you think about partnerships with healthcare organizations, understanding the needs in the landscape. I'm going to tell you in a few minutes is really a foundational element of partnership building. I think where we are now is in a phase where some of the early experimentation efforts are translating into kind of rules and requirements that healthcare entities are going to be needing to follow in the future. So now I want to move into talking a little bit about more about what we know from evidence on building those partnerships with healthcare entities at the community level. Oh, and I'm trying to multitask and take a look at the chat as well. And I saw a question about seeing the screening questions. And let me just tell you, I don't actually have them on the slides, but they're quite simple. And you can actually if you take a Google and a Google the Accountable Health Communities screening tool, it's going to pop up. I'm almost sure it's going to pop up for you in one of your first one or two Google search results. But they're like, in the past 12 months, have you struggled to have enough food to eat? So that's, for example, that's going to be not exactly the food security question, but it's going to be along those lines. And patients will get scored yes or no. So do they have the risk, or do they not have the risk? There are some other screening tools that frame the need in terms of whether the patient wants help. So the some other interventions I've studied have asked patients more specifically, would you like help with food security? Would you like help with housing? And we do find that patients answer a little bit differently. So whether they have the need versus whether they want help are a little different. You found one and it's 27 questions. Okay, so here's another thing I can tell you is that there is not there's not a finally absolutely universally accepted set of screening questions yet. And this is something that is of interest in the field, I'd say. So we haven't quite gotten to a point where there's a absolutely accepted way of screening for social risks in healthcare settings. And I think we have largely gotten to a point where there's openness to doing this screening. There wasn't a universal openness, I would say, to the idea that this is absolutely the right thing to be doing with those precious 15 or 20 minutes that a primary care physician, for example, might have with their patient. I think we've gotten to a point where that is quite well accepted, but there's not a universally kind of accepted panel of screening questions yet. And so some organizations like to design their own questions, kind of framed around their own patient population. Other organizations use some widely used ones. Another commonly used screener is called the Prepare tool. It's PRAPARE. And there are many other kind of well-used and validated tools out there. But just to say, there's not like one that everyone across the country is using. Okay, so let me tell you a little bit more about what we're learning around partnership development. So working in this area, many of you are probably already thinking, if healthcare organizations are interested in linking up patients to social care resources in their communities, there's not just going to be one resource. It's not going to be a simple process because oftentimes in any given community, there's a range of specialist organizations that help patients with particular types of needs. And so here's an illustration of just 6 basic needs where you could probably think about some organizations that are addressing all 6 of these, maybe for a certain population, maybe for older adults, maybe for younger folks, and also some organizations that are really specialized in one or another of these domains. So making linkages for patients at the patient level and also creating strong relationships across organizations at the community level can be a complex process. And this is a diagram I made up, which is mainly intended to show how this could be complex. So for organizations that are looking to take coordination burden off patients who have multiple needs, the relationships and partnerships that need to be built in even one community can be pretty challenging, can be complex. So we've gotten a chance to look at this, appreciating, kind of hypothesizing that this, is likely to be complex work. We do have some emerging evidence of how this works at the community level, and taking a look at communities that have achieved some pretty good population health outcomes. My work has focused on older adults, so looking at outcomes for older adults. We look at collaboration across healthcare and community-based organizations in those high-performing communities. We tend to see more cohesive partnership networks. We tend to see quite a bit of engagement on the part of healthcare organizations with social care providers in their communities. And we tend to see that those partnerships are focused on pretty substantive activities together. So joint planning and goal setting, where partners may adjust their own activities in relation to each other, as opposed to more simple sorts of partnership where folks are just communicating, kind of updating each other. So that can be an important step in growing a partnership and growing a relationship to be more effective. But we see when we've studied communities that seem to be quite well developed in their partnership networks, that they've actually moved beyond just kind of communication and updating and have begun kind of doing joint working. So the type of organization that I've actually studied most closely is area agencies on aging. And in the quick scan I was able to do of the chat, I saw that we have some folks representing the Aging Network already on the webinar, and others that I think are kind of represented in other sources of data that we've looked at for this project. So we have been able to look at some nationwide data on community-based organization contracting with healthcare organizations. So that is actually having financial relationships where money changes hands and kind of representing a pretty advanced and evolved form of partnership. And this is partly because folks in the area agencies on aging and also centers for independent living have been amazing at filling out surveys to document this type of activity. So this has allowed us to take a look at some evidence on how contracting has emerged over the past few years. And so the data that we have is up through around 2018, 2019. And we were able to look at services that area agencies on aging, so community-based organizations that focus on older adults and provide a range of different supports to older adults in the communities. What sorts of services were tending to get provided in contracts with healthcare entities? We were also able to dial in and look at what kind of healthcare entities they were contracting with. And so let me unpack, this is what's on this slide, but I'm going to unpack it for you a little bit more. So the services that AAAs were providing when they were contracting with healthcare entities in their areas included case management and care transition plans. So those were actually the most common activities. Also assessment for long-term care, but then also a variety of different types of services, including health education, nutrition services, transportation, and a range of others. Then when we look at what kind of organizations those AAAs were contracting with, we were able to see that the most common organization was a hospital or a healthcare system. So that's about 25-ish% of AAAs had established contracts with a hospital or health system. But the next most common type of contract partner was actually Medicaid managed care organizations. So the health plans in the state that are contracted to provide Medicaid in many states. Then, in addition to those most common types of organizations, we saw a range of other types of contract partners, from primary cares and clinics to accountable care organizations, long-term care facilities on the healthcare provider side. And then when we look at different types of health insurers, in addition to the Medicaid managed care organizations, we also saw contracting occurring with state Medicaid offices, state Medicaid plans, as well as commercial insurers, plans for dually eligible patients who are dually eligible for Medicare and Medicaid. We saw some contracting with Medicare Advantage plans, some contracting through Medicare fee-for-service, and a small number of organizations that were contracting with the exchange in their state. So knowing what kind of organizations were getting contract, what kind of healthcare organizations were involved as the partners in these contracts, and also knowing some more about the contracting organizations, so these different AAAs, we were able to actually even look at some associations, kind of what was associated with these contracts forming between AAAs and healthcare partners in their areas. So we noticed a couple of things that stood out as especially significant. So we saw that provider organization contracts, so contracts with a healthcare provider like a health system or a hospital, were especially likely in states that had adopted a lot of state level delivery system reforms for integrating care. So these are a lot of acronyms, which some of you might be familiar with, some of you might not. But basically, what they signal is that the state level health policy was creating an environment that made it easier for these contracts to emerge. So there's some things that actually the AAAs were really not in a, I mean, I guess in theory they could have been involved in advocacy, but it wasn't really, those were things that weren't based on the AAA itself. They were based on the state environment that that organization was working in, being conducive to setting up these partnership arrangements. The other thing we noticed was that when we zoned in on the insurance contracts, so contracts between AAAs and health insurers in their area, those were significantly associated with the area agencies of and aging having high business capabilities, which was something that was measured on the survey, on other surveys. These are things like having plans for kind of landscape analysis, having uh, uh, systems in place to create business plans. So really things where it did seem like the organization itself, the AAA itself, was strategizing to go out and make itself competitive for these insurance contracts. The other thing that was really important in terms of being associated with these insurance contracts was actually having a state CBO network through which those AAAs work together and contracted together. So this, again, it may be a phenomenon that some of you are already familiar with. So we're seeing that oftentimes, if you kind of think back to that complicated network diagram I put up for you in the beginning, there's a lot of organizations um, providing different types of services in a community or in a state. And so what we're seeing is those partnerships can become somewhat easier if community-based organizations take the initiative to come together as a network that a healthcare organization can then contract with altogether. And we did see that significantly associated with these insurance contracts. So here's a way to, so that's a lot of complexity. This is the graphic that we came up with to try to make sense of those findings. So the idea that when we think about potential relationships, contractual relationships forming between community-based organizations providing social care and healthcare entities that are increasingly interested in bringing in that expertise for their patients, there's two sides of this story, right? So whether these partnerships form, these contracts form, is going to be partly about the demand from those healthcare organizations. So is there a setting where those healthcare organizations are encouraged to and able to reach out for the expertise from their community-based partners? Then are those community-based partners, in this case of our research, are they equipped with the capabilities and experiences to allow them to step up and partner effectively? So it's really the key thing here is we want to make sure that there's an understanding that this isn't kind of going to be a one-sided process. It's both going to be the community-based organizations' perspectives and capabilities that need to come together with the right environment and the right pressures and the right demand from healthcare entities, whether they be insurers or whether they be provider organizations in the community, and both of those forces coming together to result in contracts forming. Or if there's kind of a lack of coming together on both of those sides, we're probably not going to see those partnerships emerge. So now I want to move into kind of the last set of points that I want to share with you around from additional sets of studies that we've done, which is kind of getting to that, how do CBOs build relationships with healthcare organizations? We know it can be challenging. Some of you undoubtedly know from your experiences that this can be challenging. So we can anticipate and know that there are issues of inadequate financing and kind of payment mechanisms that haven't in all cases quite come together to provide the right incentives for healthcare organizations to want to reach out and contract with social care specialists. Even in cases where they are, goals can be tricky to align. There can be barriers to information sharing from kind of patient confidentiality or client confidentiality perspectives. There can be challenges on kind of making a clear case for return on investment. So we know there are things that need to be overcome. At the same time, we also know that these partnerships can be possible. We see them out there in the field. We see these working productively. So there are also certainly areas where we see evidence of beneficial impacts. We see emergence of some governance structures that can ensure joint representation and responsibility. We see trusted kind of neutral conveners helping, and we see investments in relationship building helping. So let me tell you a little bit more about what we know. Um, so the last stage that our team took in understanding partnership building between our focal community-based organizations that we've studied for the longest, and that's AAA's, area agencies on aging, we took a careful look at a set of highly partnered AAA's from across the country. So we actually did this 2 or 3 years ago. So this followed up on that survey-based research that I told you about just before. And what we did for this project was we identified a set of AAA's that had reported being highly partnered with healthcare organizations in their communities. And we went out to actually, I think we did it virtually because this was in 2020 and 2021. We virtually visited those folks and tried to figure out how it had happened. So what kind of processes and what kind of context was there to support partnership development for those folks. And what really stood out in looking at what might be distinctive about those highly partnered AAA's in comparison to other areas where there wasn't such a high level of partnership developed was some distinctive features of organizational culture, which I'm going to tell you about, which kind of set the stage for some particular distinctive organizational strategies, which I'm also going to tell you about, and some particular partnership development tactics, which I'll tell you about too. So the three areas that seemed quite distinctive in these highly partnered organizations in terms of organizational culture included attention to the external environments in their local areas, openness to innovation and change, and ability to kind of do some risk taking to learn and grow and improve. Now, let me tell you a little bit about what those consist of and what strategies were used. So starting with that first area, attention to the external environments, we saw kind of three strategies that were common in these highly partnered organizations in their orientation to their external environments. So there was a high level kind of investment in monitoring trends, so kind of trying to maintain an awareness of the pressures and demands facing the healthcare sector in their area. And so that's kind of what I was telling you about in the beginning of this presentation. There was some active seeking to understand and align with partners and goals. And there was some active efforts to define and market expertise among those CBOs themselves. And so here's a couple of quotes that illustrate these strategies. So one participant from a highly partnered organization was telling us about building partnerships with the VA health system in their region, and saying that they developed an awareness that the VA has a culture, and one way that you can build trust with them is that you are early to any event. You show that you understand their language, and there's a certain culture of hierarchy. You make sure that you don't go over someone's head if you're not supposed to. So really representing this careful attunement to what's going on in that potential partner organization, and alignment with that approach. So then here's another example. On the second quote on this slide, it illustrates kind of actively understanding and aligning with the partner's goals, and actively thinking about how to define the organization's own expertise in relation to the partner's goals. So they say you have to meet their deficit needs. You can't just impose a service on them that they don't see the value of. You've got to look at their latest reports and you got to look at their star ratings. And by star ratings, they mean actually the quality ratings that get publicly reported on healthcare organizations. So these include the CMS Compare ratings, which you all may be familiar with already, but there's publicly reported kind of quality measures that bring together lots of different definitions of quality and roll those up to a star rating for a particular organization. So then the second area of culture that was distinctive was openness to innovation and change. And we saw two particular strategies that were used in this area. So one, adapting the roles, programs, and operations. And the second was developing workforce capacity to innovate. So some examples that we heard from highly partnered AAAs. One, an organization that was commenting on its building of partnerships with insurers was reflecting on the insurers said, we want to help people leaving this hospital of any age. This was a AAA. So we thought, okay, let's build on this. And the next thing you know, we have an agreement where we deal with people leaving the hospital. It's very much turned into selling social determinants of health expertise as much as it is selling it with older adults. So some kind of openness to innovation in thinking a little bit more broadly about the age that the organization was, the age range that the organization was able to support. So then the second quote is reflecting the importance of thinking carefully about the workforce needs that need to be in place to build a partnership. So this participant was reflecting it's the middle manager piece where things can still fall off the rails. That's where we're seeing the most tension in developing partnerships, not at the strategic level and not necessarily at the service delivery level, but it's at the operational level inside the middle management of all of the partnering organizations. And this is actually super, those of you who probably, many of you probably have training in management as well. So this is a really common factor that we see is important in organizational performance is that middle manager piece, which is always so critical. So thinking about the middle management workforce that's needed on both sides to make these partnerships effective. And then the final area of culture that I wanted to touch on is this openness to risk taking to learn and grow and improve. And so this is going back to that observation that developing these partnerships is going to be a risk and it is going to be a challenge. So we saw a few strategies that seemed common among these highly partnered organizations in that they were open to embracing uncertainty. They were open to balancing some calculated risks with pragmatism. And they were willing to consider accepting some short-term losses in anticipation of a future market. So taking some short-term risks in the hope that there might be a longer-term payoff. And some of the participants who shared experiences illustrating these strategies were as follows. So one organizational representative mentioned an example where they said to prove our value, we step out and do some things for free for a little bit of time to say, look what we can do. Let's see if this is something you want. We'll do this for 6 months. We won't charge you anything. We'll collect data and we'll show you what's happened. And they mentioned that they've had a lot of success with that. So being able and having the bandwidth and having the resources to provide some services without having a payment model in place. And then the last quote I wanted to share with you is from another representative of a highly partnered AAA, who was also recognizing that this can be, tough to balance internally. So this person saying there's some of us who are much more like, let's put money into this, let's build it. And then there's some who are much more like, I don't know, are you sure? And recognizing sometimes you have to pull those less sure members of the organization along. So okay, so I'll come back with a last reflection on those culture domains in a second, but also wanted to highlight the specific tactics that we saw recurring among these highly partnered AAAs. which in many cases flows from those types of strategies that I've just talked about. So we heard about setting a common agenda together with partners early. Heard recurrently about defining and marketing a unique expertise. We did hear about using tools like MOUs to ensure role clarity and accountability. And we did hear about timely communication. So that sometimes included embedding staff. In a case of a healthcare provider organization, it could be embedding AAA staff in a hospital setting or a provider organization setting. But also sometimes this included sharing records or sharing electronic systems. So, this is so. Just one more thing to highlight. In understanding what it was like for these highly partnered organizations to take these risks and to navigate the complexities of building partnerships, which in most cases represented a different way of working for them. I think I do want to just underline again that this was a challenge and seen as really quite a big thing for the organization to be doing. So not something to be taken lightly, not something that they expected to be easy, and not something in most cases that did end up being easy, but did end up being rewarding in many cases. Then I don't want to end without recognizing that there are trade-offs, and we see some evidence that kind of puts these into focus. So a colleague in Massachusetts, I think, wrote a nice piece in the past couple of years from the perspectives of some community-based organizations specializing in social care in Massachusetts who were thinking about opportunities to contract and partner with healthcare in their state and reflected on the fact that establishing partnerships with healthcare entities, be they providers or healthcare insurers, was sometimes asking them to make organizational changes that made them more similar to healthcare organizations. And healthcare organizations are great at a ton of stuff. So sometimes this meant new performance metrics. Sometimes this meant hiring clinical staff or adding health expertise to their board or their management teams. Sometimes this meant using medical language to describe their work. And this also raised awareness among the CBOs and the analysis that, some of that is great, but some of that raises some ambivalence about becoming too medicalized. And so there are some advantages to standing apart. And some of those advantages make CBOs especially well suited to supporting their clients and their community social needs. So just wanted to don't want to end without recognizing that there are trade-offs and complexities to think about. Aside from the actual kind of like efficiency and organizational change dimensions. So all this is to say, there are tensions in partnership building, right? So it really can be exciting for some folks, can be exciting and some cases can really offer a lot for populations and health. For the folks who are thinking about establishing these partnerships, you need to recognize that there is a balance between stability and expertise and independence, and then uncertainty and new territory and interdependence that comes with engaging in substantive partnerships. So I would love to take more questions and engage with folks in discussion. We also know that thinking about developing partnerships and aligns with understanding that our organizations exist in environments. And when the environment changes, organizations need to change too to adapt and stay relevant. So we know a lot about ways to do this in the management sphere for kind of adaptive organizational culture, which can be important in new ventures. And the themes that we see arising in highly partnered CBOs and AAAs around attention to external environments and openness to change also reflect kind of what we know tends to occur in adaptive organizations of all types. So that's all I've got to say that I'd planned, and I would love to address questions now.
Thank you, Amanda. That was such a good presentation. I was taking notes for the work that we're doing in Extension. We have two We have about 10 minutes for Q&A, and there's two already in the question and answer, so we'll start with those. The first is, do any of the pilots screen for social isolation and or loneliness and make referrals for interventions?
Mm, that's such a good question. So the two that the CMS, the Center for Medicare and Medicaid Services, accountable health communities model, that wasn't one of the 12 screening items in that questionnaire. But I know that there are others that do screen for social isolation, and in fact, the California-focused county-based program that I studied conducted a longer social risk interview basically with patients. So rather than using a 12-item questionnaire, they actually had the bandwidth and time to engage in a motivational interviewing uh, kind of screening with patients. And in that case, they did ask about social isolation and social supports. So I think that is definitely something that's out there. And there is a lot of growing awareness, I think, among healthcare providers that social isolation is also one of those really important determinants of health.
Another question that we have is that one of the attendees is working with a community-based organization that has been approached by a hospital system to be part of their closed-loop referral system.
Mhm.
And they ask, could you provide a brief overview of how that closed-loop system works and
Mhm.
the hospital system's expectation of what its partners can provide?
Mhm. Well, so I know what you mean, right? So one way I could answer that is be like, well, it depends on what the closed loop referral system is, depends on what the hospital wants. But I kind of think this is a very common question that community-based organizations confront. So I think I know what's behind this. So there are a variety of commercial vendors that now provide IT solutions for closed loop referral. And if I can maybe like not, this isn't going to be 100% maybe accurate, but the simplified version of this is as organizations are asked to ensure that they can screen patients for social risks and then help them in some way. The enforcement mechanism is to have a closed loop referral where you find the risk, you offer assistance by referring a patient out to a community-based resource. Let's say it's for food insecurity, and then the healthcare organization has some confirmation that indeed the patient successfully contacted that community-based resource, and the healthcare organization can kind of check that box that that patient got the care they needed. So the IT solutions that have emerged, and there are multiple companies that offer IT solutions here. These generally work by allowing a healthcare organization. So let's imagine maybe it's a nurse or a physician who documents a social risk, puts in kind of in the same way that they would use their electronic health record to put in a referral to like a a social work referral within their system or a referral to a primary care doctor. They put in a referral to a nutrition organization, but that's an outside referral. And then there's some way for that nutrition organization to tick a box later on saying that, like, yes, we met this patient. They're ours now. They reached us. Um, so that's kind of that's like the basic idea of what it is. The actual specifics of what any particular organization is going to want is going to vary by organization, but that's like the general interest that they have. And part of what's behind that could potentially be that now there are quality measures that healthcare organizations and insurers need to abide by that demonstrates that they have a closed loop referral platform of that type.
Another question. Can you tell us more about the value-based service billing model?
Yes, absolutely. So I'll try not to tell you a whole semester's worth. So I do teach Masters of Public Health students, and I do teach a Foundations of Health Policy and Management course, which is all about healthcare financing. Um, so some of you are probably familiar with the basics of our healthcare financing system. Some of you probably aren't. So basically, most of our healthcare gets paid by insurance. That those insurance financing flows come from a variety of sources. About half of financing in the country comes from government sources, either Medicare or Medicaid, and about half comes from private insurance or self-pay. Um, in particular, our Medicare programs began starting to move away from a fee-for-service model and towards value-based payment models. And the idea is to try to rein in healthcare costs. So I think we all feel in our kind of personal spheres the rise in healthcare costs. We see it in the kind of payments for all sorts of services and insurance premiums. And so value-based payment is really geared toward trying to rein in costs, so have some sort of predictability in costs, while also ensuring that healthcare quality maintains a high level. So value-based payment models are generally models that try to provide a given payment for a given outcome instead of a given payment for a given service. So if you think about a fee-for-service model, most I have a great deal of admiration for healthcare providers, and I think most of them are trying to just provide the best care that they can, right? So they're trying to bring in patients for appointments when they think those appointments are going to serve the patients well. They're trying to provide scans and services and treatments when they think those are right for the patients, right? So that's kind of my first comment. But then when you think at the edges where there might be kind of, you could go either way as far as patient health, a fee-for-service model is going to incentivize more treatments, more visits, more hospitalizations, more services, more surgeries for organizations that are looking to build their bottom line and looking to make more money. So a value-based payment model is meant to counteract that so that the incentive is really focused in on quality of care per patient, and there's not an additional incentive to do like more and more appointments and more surgeries and more services. So that's kind of the philosophy behind value-based payment. So there's generally going to be some sort of kind of a payment that's based on a patient's condition or outcome, and there's going to be quality measures accompanying it. So those are kind of the two pieces of value-based payment. A payment model that that's based on kind of what a patient needs as opposed to what they get, and then some countervailing quality measures to make sure that that the highest level of quality is being met.
Thank you, Amanda. Those were the questions that we had. I want to ask our attendees to take a few minutes to complete the webinar evaluation. Savannah and Kat have placed that the survey link in the chat, or you could scan this QR code on your slide. And we just want to thank you, Dr. Brewster, for an amazing presentation, and for all of our attendees for joining us today. The webinar was recorded and will be posted at a later date on the Nutrition and Aging Resource Center's YouTube page, and we will share that when it's available via our e-newsletter, which the sign-up link was also placed in our chat during the session today. Thank you, everyone, and have a great rest of your Wednesday.